Today we will be talking about some drugs in hemostasis. I thought I'll change a little bit in my way of presentation so that you people also will be alert and you will have some stimulation. And most of you know all these drugs, so I thought I'll pose some questions to you and then tell you some important things about it and come to the back again so that you can understand it better and retain it better. More than understanding, you should be able to retain it forever. It is not like engineering that you read for 3 months and forget it. MBBS is a lifelong story. So you have to remember it and why those are not used and why the new ones are used, what are the advantages, and why, in some of the cases, we still hold back to the oldest one. Why is it so? So these are the reasoning outs what you should have whenever you use a drug in any system for that matter. So today we will take up drugs in hemostasis. So it consists of antiplatelets, anticoagulants, and fibrinolytics. First, I would like to speak the oral drugs first, and then I would like to speak on the other drugs where we are using it in certain this one. Otherwise, it is always an ICU setup or a hospital setup what we see regarding these agents, and most often it will be helpful for specialists and super specialists than to a normal person. But definitely for all neat exams and understanding and practicing and re-prescription, filling of the prescriptions, in all these cases, all these drugs are of more use today because patient also cannot wait going to with such large distances, and so they come back to us once more. And so you have to judge whether to give the old one or the newer one or the advantages or whatsoever or what not. So if you have any problems, you can just post it so that we can also give you the fair answers in which you will be deciding further in your practice or in your positions or whatever it is. Okay, with this, I'll just come directly to a question. Which of the P2Y12 ADP receptor antagonist reversibly binds to the receptor? So, we are talking about antiplatelet agents. They are of three types. One is the normal one, what we use is low dose aspirin. The second one, most often we use clopidogrel, but the others also have taken a role today. And third one, exclusively in ICUs, that is GP2B3A receptor antagonist, where it is only by IV infusion. So three varieties are there. In that, the second variety is the one which is this, which of the P2Y12 ADP receptor antagonist reversibly binds to the receptor. And the second question is match the drug with the therapeutic use. So you have to say low dose aspirin where it is used, eptifibatide where it is used, prasugrel where it is used, DAPA where it is. I hope you know what is DAPA also. If not, we will come to back to it again. So remember this, we'll come back to these questions once these antiplatelet agents are over. So with this background, I would like to give you a small hint on how clotting mechanism takes place with coagulants, fibrin, and platelets. And later on, we'll come to the 8 antiplatelet agents and come back to these questions once again. So, in our body, the formation of the clot starts with the formation of fibrin that together with platelet plug helps in coagulation. So, there is activation of platelets forming the hemostatic plug. Then there is degradation of fibrin, that is fibrinolysis. Then the vascular endothelium also produces antiplatelet action by releasing PGI2, also synthesizes PGI2, and other synthesis of other substances are also seen in the formation of the clot. So three important components: platelets, fibrin, as well as the coagulating mechanisms. Now, I have just enumerated anything which is deep and specific which you have not understood. I will try to explain it, but together you have to have a little bit of physiology to know pharmacology. That's the reason why I have put these slides. First is the blood coagulation. There is both intrinsic as well as extrinsic pathway. Intrinsic pathway is known as contact pathway, and this is not physiologically significant. The APTT or the kaolin kephalin clotting time is prolonged if the defect is in the intrinsic system. That means it might be congenital, or there may be deficiency of certain factors, or any of these things can be there, including antithrombin 3, factor 10, factor 2, anything can be there. And so whenever this pathway, it is not at all significant, but if there are any deficiencies or congenitally deficient, then this pathway is very important, where we see when we do some investigation, we see that APTT is prolonged. The extrinsic pathway is also known as physiological coagulation, where all components come from outside the body, totally from outside the body. So from outside the body, all the factors are stimulated, and hence only PT is prolonged, and it is expressed as INR, where we talk day in and day out as INR, especially when warfarin is administered, because warfarin is a drug where we use it day in and day out, because it's very cheap, but otherwise it is totally an unwanted drug with lot of drug interaction, and the person might die of warfarin than the real disease whatever he has. So the fibrin, the first component is the coagulation factors and the pathway, and both the intrinsic and the extrinsic pathway, including the clotting factors, antithrombin 3, factor 10, factor 2, fibrin, plasminogen to plasmin, then plain presence of plasmin, fibrinogen to fibrin, and along with that, there are platelet aggregation, which we will see in the further slides. The next one is the fibrin inhibitors, where the main one is antithrombin 3, where we will see that there is no coagulation happens. Protein C and S, as well as prostacyclin, that is PGI2, which is present in the walls of the blood vessels, Next, thrombogenesis takes place through arterial thrombus, which may break because of the embolism in the brain, if it is from the left side of the heart or the carotid artery. So the difference between the arterial and the venous thrombus, you have to differentiate, because the treatment differs here. So arterial thrombus, it's mainly in the arteries. The main constituents are platelets. The consequences are infarction in whichever organ it is, or the death of the tissue. And later on, embolism also can occur in certain of the places. And mainly the drugs used only for prevention, I'm telling you, it is antiplatelet agents. Antiplatelet agents. Whereas in the venous thrombus, we see the fibrin is the main constituent, embolism is a consequence, and mainly we are using heparin or oral coagulants. And as I have told you in the last slide, arterial thrombus may also break, causing the embolism if it is from the left side of the heart or the carotid artery. Now, these are the various classifications what you see in your regular textbooks. That is the antiplatelet agents. Amongst them, the most important ones are as low dose aspirin, not just aspirin, it is low dose aspirin. Then we have clopidogrel, nowadays prasugrel. Then the other ones most often are used in ICUs. Amongst the anticoagulants, we were using heparin. Now the most common ones are low molecular weight heparins, but because they have to be given parenterally, we are using either the analogs of herodin or the thrombin inhibitors, or we are using the oral ones like rivaroxaban, dabigatran, warfarin, and apixaban. And these thrombolytics are mainly used in IV setups and corporate as well as ICU settings, whereas the treatment of bleeding, complete bleeding, is heralded by protamine sulfate, which itself is an anticoagulant, tranexamic acid, vitamin K1, idarucizumab, as well as EACA, previously called, that is now aminocaproic acid. So this is in general, we have got a list of things, but the ones which are using are only these, where we use very, very commonly. Now, as I told you, you have to know little bit of physiology. So here I am showing you the formation of the clot through various mechanisms. This is half page. The next one will come in the next slide. The resting platelets have these in the subendothelium, which are healthy, intact, and in the endothelial cells, and collagen fibers are also formed, and they also inactivate these GP2B3A receptors in the resting platelets, and also the mechanism from ATP to cyclic AMP, and also the calcium release is taking place, and the prostacyclin in the blood vessels and the blood vessel wall of the endothelial cells. So these healthy intact endothelium releases prostacyclin into the plasma, which is an anti-aggregatory mechanisms. Prostacyclin binds the platelet membrane receptors, causing synthesis of cyclic AMP, and cyclic AMP stabilizes these receptors and inhibits the release of granules containing platelet aggregation agents or calcium. Next, the platelet adhesion takes place. Adhesion, activation, aggregation. Three A's are important for the formation of a clot. That is platelet adhesion, platelet activation, and platelet aggregation by various mechanisms through thromboxane A2, ADP, serotonin, platelet activating factor, and also PGI2. The next step will be the formation of the fibrin. From thromboxane A2, there is aggregation of platelets where it activates the GP2B3A receptors, and then you see that there is elevated calcium. Calcium alone is sufficient in various parts of the body to contract and conduct or all those things. Then there's a formation of platelet fibrin plug, and hence later on the fibrin clot is formed where we do not want the clot, and hence that is converted to plasmin to fibrin and fibrin degradation products, and hence fibrinolysis takes place, so that there is no clot formation inside the body. And inside the body we want the blood to be flowing, never to clot, whereas outside the body we want the blood to clot, because we do not want to lose the blood from our system. These are the antiplatelet agents what we are using today, day in and day out. Amongst them, as I have been repeatedly telling, again I'll tell you repeatedly that these platelet aggregation inhibitors are the most important ones, which are most often given orally, apart from the last two, which are injectable. So of that, the common ones are aspirin, which acts by irreversibly inhibiting the TXA2 enzyme, which is one of the component in the cyclooxygenase pathway, which irreversibly inhibits the enzyme. Aspirin inhibits the TXA2 enzyme for the lifetime of platelets, that is 7 to 10 days. 7 to 10 days it is blocked. But why do we give it daily? Think why do we give it daily, though the action is for 7 to 10 days for the lifetime of platelets. And the main use is in primary prevention, most often in patients with diabetes as well as hypertension, where they are more prone for cardiovascular diseases, more so of 10 years of these conditions, and acute coronary syndrome, where we use 325 soluble aspirin, stable angina or spast and recent stroke, in all these 150 milligrams, whereas in primary care it is only 75. So you have to remember where 75 is used, where 150 is used, where 325 soluble aspirin is used, and it is the most needed one in today's, because geriatrics is the most common population what we are seeing today. So here with aspirin, as all of you know, angioedema or allergy is very common with all the drugs what we take, including the food we eat. But the most common one is, most of the times all these people lose 5 ml of blood every day when the patient is put on aspirin. This is a known fact. Okay, so bleeding is very common because the antagonist in the gastric mucosa, there are H plus K plus ATPase pump which secretes HCl, and the opposite is the prostaglandin which secretes mucus. Now this aspirin will inhibit the prostaglandin in the stomach mucus also, so that there is no mucus production. HCl is grandly enjoying in the stomach, and so this is the one which can proceed to bleeding after continuous use. So the main drug interactions are, because this is only the irreversible inhibition seen with the NSAIDs. None of them are, all the others are reversibly inhibiting. So when you use it along with ketorolac is commonly used in post-operative pain. We can see increased bleeding. Then we see this pseudofovir, where we see nephrotoxicity, because all these NSAIDs are known to produce nephrotoxicity because of prostaglandin inhibition, fluid and water retention, edema, nephrotoxicity can increase. Then probenecid, where there is decreased uricosuric effects, and non-selective COX-1 inhibitors decrease aspirin efficacy when used all alone. So we have to look at the CBC as well as LFT whenever we are using aspirin continuously, and all these drugs are most of the time lifelong drugs. Silestazole is a peripheral vasodilator where we use it in peripheral vascular diseases like claudication, or in any of these peripheral arterial diseases where we see, and almost the same action is seen but through PDE3. PD is phosphodiesterase 3 inhibitor. Okay, and can be given once daily also because half life is very long. Clopidogrel is another drug where we use alternative to aspirin whenever they are sensitive to aspirin or resistant to aspirin, or it is used along with aspirin as DAPA dual antiplatelet therapy. Okay, so this is the one which is very commonly used. This is the drug which is P2Y12 ADP receptor antagonist. Also, there are another three drugs, that is prasugrel, ticlopidin, and ticagrelor. All the three are P2Y12 receptor antagonists, and they inhibit the second step in the platelet aggregation. The plasma half-life are respectively 6 to 8 hours, 8 hours, 12 hours, as well as 6 to 12 hours, but we prefer either clopidogrel or prasugrel. The advantages being the clopidogrel we use along with aspirin, but nowadays prasugrel has shown to be very effective with quick onset of action also, and these are given most often by these interventional cardiologists for about 1 year, twice daily, but we have to monitor the bleeding. That's the only problem with this. Otherwise, there is no other problem. Clopidogrel is very nice, but it causes neutropenia, and also it is an enzyme inhibitor. You have to remember all enzyme inhibitor drugs where it will increase the action of the other drug given along with that, and can increase the toxicity and also the duration of action of the second drug. So these are the problems which are met. So you have to monitor these things. Next one, ticlopidon, no more used because of its neutropenia and granulocytosis. No more used at all. I have told you about ticagrelor already, the same problem, but it is comparison with one another. We don't use either ticagrelor or ticlopidon because of these reactions. Normally, we use in ICU or in wards prasugrel soon after MI, okay, or undergoing PCI. Later on, for 1 year, we will keep it them on prasugrel as of today, and then later on switch on to either aspirin or clopidogrel, depending on aspirin sensitivity or resistance. Otherwise, we do not use. Previously, instead of prasugrel, DAPA was used for 1 year, aspirin with clopidogrel. The injectable ones are always used in ICUs only. Amongst them, normally we use abciximab very commonly, and eptifibatide and tirofiban are also used. All of them have got the same mechanism, and it acts within the half-life is only 10 to 30 minutes, and the last dose effect will be 12 hours, and it is used in all cases of unstable angina, non-STEMI, PCI, etc. And as you know, IV route of administration itself causes many of these problems, and the most common one being hypotension as well as thrombocytopenia. So as said, all these agents do have most often bleeding as the main component, and so you have to be careful with all these agents, and you have to monitor for bleeding and ask drug history, the adverse effect as bleeding. The important differences between these two, and so why do we use these very commonly? The specificity is more for eptifibatide and tirofiban than abciximab, and abciximab is a monoclonal antibody. How do you recognize it? MAB, monoclonal antibody. The plasma half-life is very short, so you have to repeat the dose, whereas with the other two, it is quite long. The platelet binding action is also very long with abciximab, whereas it is short, and we want only short plasma binding activity, platelet binding activity, because it is ICU. We do not want good bleeding and other things. We want to restrict, and the elimination is renal, so obviously you have to monitor renal parameters when you give these two. So based on the patient and based on these things, whether we want it for a short time or a long time, depending on this, we try to use these GP2P3A antagonists. Now, the very important note what you have to remember is oral antiplatelet drugs are used only for prophylaxis of arterial thrombosis, while parenteral drugs are used for percutaneous angioplasty, ACS, unstable angina, non-STEMI, to reduce the platelet loss during the dialysis. So this difference should be kept in your mind whenever we are treating patients, or when the patient comes with a drug history of adverse events, especially bleeding. You have to be careful, and most often we would have put on two or three of the same generic name but different brand names. In such cases also we see all these problems. So now coming back to this question, I think now you can answer these things. Which of the P2Y12 ADP receptor antagonist reversibly binds to the receptor? Clopidogrel, prasugrel, ticagrelor, or ticlopidin? The answer is clopidogrel. Match the drug with therapeutic use. Low dose aspirin. Uh, Low dose aspirin mainly for prevention. But as I told you, it is 75, 150, 325 milligrams, what you have to remember in various conditions. Eptifibatide mainly for angioplasty, PCI, and non-STEMI. Prasugrel post-MI for 1 year. DAPA dual platelet and dual antiplatelet therapy, that is clopidogrel with aspirin. Most often we were using 1 year after post-MI. Now it has been replaced with prasugrel. So this is the way you have to answer, and you have to be good at this, because you have to know where to put and why to put these drugs and how to put these drugs. You have to be very clear, so as to say you have to know more about the adverse effects. Like for example, clopidogrel, neutropenia, prasugrel bleeding, ticagrelor, we have various drug interactions as well as bleeding. Ticlopidin, neutropenia is most common, and hepatotoxicity. For that, it is almost taken off, and only the other drugs are of use. Now, coming to anticoagulants. So again, we will see just a glimpse of coagulation pathways, what I told you, extrinsic and intrinsic pathway. In extrinsic pathway, there's a tissue damage, bleeding starts. Why that starts? Because of all these factors will be in these conditions. And so now what happens is all the factors are converted to their activating factors, that is 7, 10, 2 from the extrinsic pathway, whereas from the intrinsic pathway, when it touches the glass or the kaolin or the blood vessels, the 12, 11, 9, 10, and 2A. So these are the ones which are activated. But so these are extrinsic and intrinsic. The common pathway starts from factor 10 to 10A, where 10A, in presence of 10A, prothrombin gets converted to thrombin, and in presence of thrombin, fibrin gets converted to fibrin, and in presence of factor 13, the fibrin which is soluble will get converted to insoluble fibrin, which can be stabilized clot. And so we see that the clot is formed and the bleeding never occurs, and we are reducing the content so that we are quite safe. So here you see that all these pink boxes are shown the factors inactivated by fibrin, and we see that we have got all the drugs here, that is low molecular weight heparin, which we commonly use, whereas with antithrombin factor 2 and factor 10 we have unfractionized heparin, and hirudin only factor 2A, that is direct thrombin inhibitors, that is injectable ones, and vitamin K dependent factors are 2, 7, 9, and 2, 7, 9, and 10. So these are the ones where we have various anticoagulant mechanisms, and we are using very commonly in these cases. Unfractionized heparin, which is replaced by low molecular weight heparin. We have got only one use for unfractionized heparin in emergencies, otherwise always low molecular weight heparin. So when we do not want, or when there is hit in case of heparin or low molecular weight heparin, that is heparin induced thrombocytopenia, we use hirudin, that is thrombin inhibitor. And whenever we want to shift to oral, we use warfarin, which acts on 2, 7, 9, and 10, and gamma carboxylation, so that, and which are all vitamin K dependent. So it is a pure vitamin K antagonist where we use it, and also inhibits various factors, all these factors. So you have to remember to replace the factors or the vitamin K in any case of warfarin overdose, whether you want it urgently or whether you have some time to spare, so that you can use two of the antidotes simultaneously in whatever the position the patient is. Now, a word before this, a word about unfractionized heparin, as I told you. See, the problem is you have to know coagulation at various levels, which are the factors which are inhibited. So, you can use at those stages whatever is needed. So, in case of unfractionized heparin, you see that it will stimulate antithrombin 3, okay, and also factor 10A, then 2A. So it is inhibiting almost at three places. So you can see that the adverse effect is bleeding. This is one component. Second component is heparin should always be given by IV infusion. Okay, and it's always expressed in units. I think you can think of other drugs which are you expressed in units in pharmacology, which I'll tell you in the last slide. Okay, so this is also expressed in units, and the only indications for, and also before that, the characteristic features are it is only in the vascular compartment. So it has got a very low volume of distribution. So what is the advantage of low volume of distribution? You can target with an antidote or dialysis. When it has got a large volume of distribution, that means it is going out. That means it is getting stored in the muscles or liver or brain or fat. We cannot take it out by dialysis, or we cannot give it by a single antidote. We have to wait for the drug to get excreted. By that time, we do not know what to, we really do not know. Only it is GOK, God only knows. So this is the problem what we have. So there are advantages with this heparin. That is, it has got low volume of distribution. So we can use an antidote, or we can use dialysis in the, and remove the heparin. But at the same time, it has to be given only by IV drip. The more common adverse effect is bleeding, because it blocks at three levels. And so bleeding is the main problem with heparin. So you have to keep on monitoring, and you have to keep the anticoagulant at the side. But that anticoagulant again has an anticoagulant effect. So this is the problem. And this antidote has an anticoagulant effect. And so that is the problem what we face. And so you have to be really careful. As soon as you keep on monitoring, as soon as INR increases, or when we see some sort of bleeding in any case, we have to immediately stop the drip of heparin and take the role of fibrinolysis or of platelet inhibitor, platelet aggregation inhibitors. Whereas with low molecular weight heparin, it is little more concise. It blocks only 10A, which when it blocks 10A, further it cannot act. So the bleeding component is reduced compared to heparin. Now, further, we want it in further cases. So nowadays, we are using oral thrombin inhibitors, where we should give it to the patient and send them home. In such cases, we are you directly acting on thrombin, that is 2 and 2A, where it acts at the last step, so that the bleeding component is minimized. Monitoring is not needed. Clotting factors per se are there in the body, so that there is no other problem what we see with heparin or low molecular weight heparin. So you have to make a box. I didn't want to make a box because this should remain in your brain. So for that reason, you make three columns: heparin, low molecular weight heparin, then thrombin inhibitors, both injectable as well as oral thrombin inhibitors, in that factor 10A and 2A. So if you make it like this, then you can find out antithrombin 10A, 2A. In the rows, you make it as antithrombin, then 10A, 2A. So here what happens for heparin, all of them are tick. whereas for low molecular weight heparin is only 10A, whereas with injectable thrombin inhibitors it is only 2A, and oral thrombin inhibitors also 2A. But in hirudin, there are a little component of the other factors also, where we can see little more amount of bleeding in such cases, where we do not see with this oral thrombin inhibitors, especially with dabigatran. So these are the various differences what you see, and hence how we are using it day in and day out can be managed very effectively. So with this background of heparin and the adverse effects, as I told you, heparin induced thrombocytopenia, bleeding, osteoporosis, then alopecia. All these are the main problems with low molecular weight heparin, with heparin, and so and it has to be given, though it can be given subcutaneous and IV. Most often we use it in ICU, so most often IV. It's expressed in units, but we have to be very careful regarding, because it has got a low volume of distribution, so we have to be very very careful. So we have developed low molecular weight heparin nowadays. The most commonly used is enoxaparin, and the advantages of these low molecular weight heparin is good bioavailability on subcutaneous route itself. What is the advantage of that? You can send the patient home, he can inject himself, cost is very less. So what do you mean by good bioavailability? What do you mean by the definition of bioavailability? The amount of active drug reaching the systemic circulation when given by a non-vascular route. I hope you have understood. When when a drug is given, what is the definition of bioavailability? Bioavailability is a phenomenon when a drug is given by a non-vascular route. That means not by IV. Okay, and especially by oral or by subcutaneous. The active form, why active form? When you give oral or subcutaneous, it may undergo first pass metabolism in the stomach or in the liver, and in the liver by hepatic blood flow or by enzyme induction. So this comprises of whole of first pass metabolism. So the active drug reaching the systemic circulation. Okay, the active drug, the amount of active drug reaching the systemic circulation when given by a non-vascular route is known as bioavailability. So, for example, you take propranolol or lignocaine. Both of them are metabolized first pass metabolism by hepatic blood flow. So when see normally, even if we are in coma, when we take oral or orally, especially orally, it enters into the stomach. From there, portal circulation. Certain amount gets metabolized in the stomach because of enzymes. Then portal circulation. From portal circulation, whether you want it or not, it goes to the liver. In the liver, two types of first pass metabolism because of increased hepatic blood flow or because of enzyme induction. The drug is degraded. Hepatic extraction ratio is there, and so from there, whatever drug reaches the other blood vessels, that is the systemic circulation, that amount of active drug is known as bioavailability, which can occur with all the routes except IV, because with IV it is reaching the systemic circulation first and then the liver. In all the other routes, it will reach the liver first, at least to 0.1%, and then to systemic circulation. So good bioavailability is there even on SC route. The advantages of SC route are patient can inject himself, patient can go back home, cost is very less. Though the cost of the injection is more, these things provided you can match with that and convince the patient. Long action, so you can give just once or twice daily depending on the amount of thrombus, the area of thrombus, etc. Because it inhibits only factor 10, less bleeding. Because of this, less osteoporosis, no monitoring of APTT or PT or BT is required, no hospitalization is required. The only problem is because it is excreted by renal, you have to think of renal functions, creatinine and renal parameters to be seen whenever we are using low molecular weight heparin. And there is partial antagonism with by this antidote, that is protamine sulfate, and it is quite expensive. And remember, protamine sulfate itself is an anticoagulant, so you have to be careful when we are using this protamine sulfate. Now, coming to this direct factor 10A and direct thrombin inhibitors, before this, a word about warfarin. I think I'll reach this and then go back to the next slide. I think little bit of problem has occurred here. So the first oral anticoagulants which was used are warfarin. Okay, this warfarin, as I told you, this is a vitamin K antagonist. The mechanism of action, why I have depicted here is this sort of diagram is nowadays given even in NEET exams. So that's the problem why I have shown, that's the reason why I have shown this figure. So here what is happening is the mechanisms are going parallelly here. So NADP is getting converted to NADPH, NADPH to NADP. In presence of this, vitamin K is converted to vitamin K epoxide, that is in the oxidized form, and this converts vitamin K in the reduced form, which is a polypeptide precursor of clotting factors, that is 2, 7, 9, and 10. So you have to remember three things. It is a gamma carboxyglutamyl residue which activates the clotting factors 2, 7, 9, and 10. Okay, and this will activate vitamin K reduced form to vitamin K epoxide in presence of carbon dioxide and oxygen, and also in presence of NADP. Warfarin inhibits these factors. So it inhibits not only 2, 7, 9, 10, it also inhibits gamma carboxyglutamyl residue and also vitamin K. So three steps are involved, and you have to remember three steps whenever there is an overdose of warfarin. So you have to write the prescription, document it properly because of these problems. And this drug, even today, it is prescribed because of its low cost, especially in atrial fibrillation. And the patient might not die of fibrillation, he might die of warfarin overdose. So you have to be doubly careful. So because of this, you have to convince the patient and go on for oral thrombin inhibitors, which are quite safe. The and also more than one portion is bleeding, two faces of the same coin. One problem is bleeding, the second problem is drug interactions. This you have to remember day in and day out, because we see number of patients using alcohol, using low dose aspirin. These two are the main component, and nowadays we see many of them suffering from tuberculosis, and many females on oral contraceptives. So these are the problems which are seen. And also we have certain of the things like pregnancy or certain diseases like nephrotic syndrome. In these cases also, these are the problems what we have met. And so these are the main drugs what we see, like acute alcohol intoxication, amiodarone, antiarrhythmic, fluconazole, antifungal, metronidazole, first choice in anaerobic infections, sulfamethoxazole, trimethoprim, combination is cotrimoxazole, a drug of choice in pneumocystitis, gyrivacin infection, tetracyclines no more used except doxycycline, especially in acne and in very chronic diarrhea or resistant diarrhea, when it is not useful, when it is useful in other in these infections when the other drugs are quite resistant. So these are all inhibitors, so they will potentiate the anticoagulation, and aspirin together will inhibit the platelet aggregation, so bleeding will be more. In case of chronic alcohol ingestion, barbiturates, dicyclocin, rifampicin, oral contraceptives, in all these, you see there is stimulation of the metabolism of warfarin because of enzyme induction or by the by enterohepatic circulation, etc. So there is attenuation, and also pregnancy and nephrotic syndrome adds to these combinations. Okay, so with this, I want to tell you about this direct factor 10A and direct thrombin inhibitors, that is fondaparinux, rivaroxaban, dabigatran, and apixaban. So all those are specific. Amongst them, direct factor 10A is fondaparinux, and direct thrombin inhibitors are rivaroxaban, apixaban, as well as dabigatran. They have got a rapid onset of therapeutic effect. So you have to understand rapid onset of action, not that rapid onset of therapeutic effect. Whatever action you want at the end, you see quite quickly. And there is consistent effect. There is consistent effect. There is no peaks and troughs. Low bleeding rate because it is very, very specific. Too many clotting factors are not there. No monitoring is required because with warfarin you see too many factors, so bleeding might be more, so you have to match INR, etc. higher safety margin, whereas warfarin has got low safety margin, and also it's a plasma protein bound drug. So you have to be careful. You have to see the dose whenever you are using two plasma protein bound drugs. Binding to the same albumin site, warfarin will get displaced, and so what happens? There may be too much of bleeding. So you have to be careful. For that reason, we can shift over to this, and less drug interactions, whatever I showed you now. And disadvantages of warfarin: short action leading to loss of therapeutic effect, risk of thromboembolism, and also non-compliance. Patient may say, I have forgotten why to take drug, why this is needed, etc., etc. These are the problems what we see with warfarin, which is not seen with these four drugs what we are using it today. So now when we come to the antidote of these, when protamine is administered in absence of heparin, it produces anticoagulant and antiplatelet effect both. So fibrinogen and platelets also. So you have to be very careful whenever we use it in the overdose. In HIT, we are using heparinoids such as lepuridine, bivalveridine, argatroban. They are mainly indicated alternative to prevent the thrombosis in case of type 2 heparin-induced thrombocytopenia, where heparin cannot be used because heparin has already induced thrombocytopenia. We cannot use, especially in unstable angina in such cases where there is already a deficiency and other things are, or other concomitant diseases, bleeding diseases. In such case, these heparinoids are used. The common one which we are using today is bivalveridine or argatroban. Now, coming to this INR, which is the real game show of all of us, where we are using this warfarin, etc., especially with warfarin. INR is required for various indications of oral anticoagulants, and I have just shown the number. I have not shown you how to do it and all. It takes a long time for that. I have just told you the ratio in which disease it is really needed and how we use it. So in INR ratio of 2 to 2.5, it is used for prophylaxis of DVT, that is deep vein thrombosis, including orthopedic surgeries, where the nowadays we because of what to say. We are using blocks. Previously, we were using spinal or epidural or general, where the patient were put on the lying down position for about a week. Patient used to die of thromboembolism. But now, because of blocks, these things have reduced greatly. But still, to be on the safer side, when we use these things, the INR ratio 2 to 2.5 for prophylaxis of DVT, including orthopedic surgeries, and INR 2.2 to 3 for treatment, that is for prophylaxis to prevent, whereas here it is for treatment of pulmonary embolism, then DVT, prevention of thromboembolism in high risk patients, that is in MI, mitral stenosis and atrial fibrillations, and TIA, and INR 3 to 4.5 for recurrent DVT, pulmonary embolism, prosthetic heart valves, as well as arterial diseases. So these are the ones what you have to note in case of this. The calculation of this internationalized normal ratio is to determine by the fasting blood sample collected after 10 to 12 hours after the last dose of anticoagulant, and PT is determined and calculated as follows with the control value. So how do you calculate it? It is INR equals PT of the patient. Okay, PT of the patient over PT of the control. So INR value of 2 to 3 corresponds or comparable when the thromboplastin, human thromboplastin, is used as per recommendations of WHO, and the 1.2 to 1.5 when rabbit thromboplastin is used. So these are the two differences what you should note, and this reagents with lower ISI are more sensitive to this reaction. So you have to know wherever they are used and how it is used and what are the ratios what you should know, and accordingly used in these various conditions. So now coming to fibrinolytics, the last topic, fibrinolytics. Again, I have put few questions here. All fibrinolytics you have to just enumerate. There is no classification like anticoagulants where we have injectable and oral. Here we have directly just enumeration, the oldest one being streptokinase, the latest one being retiplase as well as tenecteplase. The middle ones are urokinase, then we have urokinase, anistreptase, altiplase. All these are the middle ones what we have. So remember these two questions. Which is a fibrin selective? Because it rapidly activates plasminogen that is bound to fibrin. Altiplase, fondaparinux, argatroban, bivalirudin. The next question is: a 58-year-old man receives IV alteplase for acute stroke. 5 minutes later, he develops angioedema. Which of the following drugs have increased risk, which will increase the risk of angioedema in this patient? We'll come to the answer after these few slides. So just a little bit of brainstorming sessions. So here, as I told you, the fibrin clot is formed in presence of 10A, where prothrombin is converted to thrombin, and in presence of thrombin, fibrinogen is converted to fibrin. So fibrin clot is formed when it is from outside. Okay, this fibrin should be lysed when it is internal, because we don't want clot inside the body. Okay, we don't want the clot inside the body, so you have to be careful whenever you are treating some deficiencies inside the body, or when you are treating a thrombosis, or when you are treating bleeding, or when it is coming out of the body. So with all these three, if you remember this, you can really take down which drug to be used in which places. So here you have seen the plasminogen is activated to plasmin by the activators, that is endogenously by factor 13A, tissue plasminogen activator, as well as kallikrein. These are the endogenous tissue plasminogen activators. In the body, blood should be in the fluid stage, so there should be endogenous inhibitors also. We have alpha 2 antiplasmin and alpha 2 macroglobulin, which are endogenous, So this is balancing in our body, and so we see to it that the blood is in the fluid state throughout. Now, when the blood has become a clot, we have to make it again into the fluid state. So we are giving it a plasminogen activator. Plasminogen activator, that is streptokinase, urokinase, altiplase, retiplase, tenecteplase. All of them have the same mechanism of action. They only differ in their adverse effects and their pharmacokinetic features. Otherwise, the mechanism is same for all of them. For all of them. So they activate this plasminogen to plasmin, which will convert fibrin to fibrin fragments, which is soluble, and so hence the make the solution or the blood to a fluid state, so that there is no question of clot, thrombus, or embolism. So I have shown you here so that you can remember this. This should come in front of your eyes whenever you see any drug in ICUs or in your tests or wherever you want it. So here I'll focus mainly on certain of the points, not all of them. So here streptokinase is the normal drug what we use in day-to-day practice, especially in PHCs or in general hospitals. Why is this so? Because this is very cheap. Cheap means it is about 3,000. Okay, so that is also considered to be cheap nowadays. This is obtained from beta hemolytic streptococcus. So obviously, the next step which should form in your brain is beta hemolytic streptococcus. So it forms antibodies. So when there are antibodies, it will remain in the body. So whenever further attack is there, it tries to negate it. So for that reason, you have to give very high dose, and so it is given in million units, in million 1.5 million units in 30 to 60 minutes as IV infusion. Why such high? Two things. Because one, mainly the antibodies would have attained, and so you have to give in high dose, and once you give this dose, you should not repeat at least for 6 months. These two should be remembered in streptokinase, which is not there with others, and so all the other higher hospitals are using the others rather than streptokinase. The adverse effects are also same in almost all of them, but this is the main difference what we see with streptokinase and the other drugs. So, and most of the uses are also same, because it's always used either by IV bolus or by IV infusion. The next one was urokinase, which was obtained from human urine, and this should be given. The dose is less because there is no question of antibody developing or any reaction developing. So 4,400 units. So that is 1.5, whereas this is 4,400 international units. And the second point, what I forgot to tell you, is it binds both to bound albumin and the circulating sorry, not bound fibrin and circulating fibrin. So when it binds to both, bleeding is more. So 4 points to be remembered in streptokinase. It is obtained from streptococci. Second, beta hemolytic streptococcal antibodies is formed. Third, because of that, we are giving in high doses. Fourth, it will act both on bound as well as the circulating fibrin. So because of these four factors, what happens? This causes more bleeding. More bleeding leads to more hypotension. So these two are the main adverse effects what we see. And because of this beta hemolytic streptococcal antibodies and other things, we may see even allergic reactions to a great extent with streptokinase also. So these are the 5 points to be remembered with streptococci. The game is over. With urokinase, almost all the five are lessened. The first three are never there. Hypotension and bleeding are there with all of them, but considerably low combined compared to streptokinase. All of them are given by this one IV infusion, except tenecteplase and retiplase, which is given by bolus. So the only difference with urokinase is it is obtained from human urine. Altiplase, from altiplase, it is specific. It does not bind to circulating hemoglobin, circulating fibrin. So what happens? The bleeding is less. Bleeding is less, or we need not see bleeding to a very great extent as we see with streptokinase or urokinase. And so this is, and the dose is also very less, that is 100 milligrams in 90 minutes based on weight, whereas the other two you can give even by IV bolus in the periphery, and so send the patient to the tertiary hospital, giving them aspirin 325, metoprolol if the heart rate is more, 12.5 milligrams, atorvastatin 80 milligrams, because in addition to HMG-CoA reductase enzymes, pleiotropic actions, and the atorvastatin 80 milligrams, the 325 of soluble aspirin, because it should act immediately, clopidogrel of 300 milligrams, and if the heart rate is more than 100 or even more than 90, to be on the safer side, metoprolol 12.5 milligrams. To give them these along with nitroglycerin, give them a bolus dose of retiplase or tenecteplase, and send them to a tertiary hospital. Within that time, if you send it within about 4 hours, the patient is back home within next 3 days. So these are the advantages what we see with these drugs. So most often nowadays in the corporate and in the higher ends, we use altiplase, tenecteplase, and retiplase, whereas in PHCs and general hospitals, and where there are constraints, we use normally streptokinase. Urokinase is not available to a very great extent, and all the indications are same, mechanism of action is also same, and as I told you, fibrin specificity is low because it can bind both to both of them. With urokinase and streptokinase, it is high because it binds only to the clot fibrin, not to the circulating fibrin. So these are the few differences which this should come to your, it should remain in your brain and come in front of your eyes whenever you see these sorts of drugs, patients, or in your papers. So as I have just reinforced these things because of streptokinase problem of allergy, more bleeding, more hypotension. Because of that, I have given you an insisting thing that what can be given as IV infusion and IV bolus, and send them to a tertiary hospital as quickly as you can plan it accordingly. So now contraindication to these fibrinolytic therapy. Intracranial hemorrhage, so you have to do an MRI or CT scan or whatever it is, or clinically in those days they used to find out according to the signs and symptoms. So history of intracranial hemorrhage, CVS, etc., or aortic dissection or uncontrolled hypertension, bleeding disorders, then patients on anticoagulants, esophageal varices, ulcers, tooth extraction, fractures, or even during pregnancy because of antiphospholipid antibody, etc., etc. Now, whenever we use these drugs, bleeding is a common adverse effects. Vitamin K1 is the antidote for oral anticoagulant if you can wait for 24 hours. If you cannot wait for 24 hours, it is fresh frozen plasma. Why? Because they contain all the factors. That is the reason why you have to use fresh frozen plasma for acute and vitamin K that takes minimum of 24 hours, so you can use this vitamin K only if you want to wait after stopping the oral anticoagulant also. It takes 24 hours so that we can block all the three steps, that is gamma carboxylase enzyme, then 2 7, 9, 10, as well as the vitamin K production. So all these should be taken care. So it takes 24 hours, whereas fresh frozen plasma contains the factors, so you can stop bleeding immediately. And protamine sulfate is used to counteract the overdose of heparin and EACA, epsilon aminocapric acid, for fibrinolytic therapy. That is, the ones what I told you in the previous slide. Now, here, most of the times in acute MI, we see that both fibrinolytics and anticoagulants are administered. So, heparin is administered simultaneously with alteplase or other short-acting TPA to reduce the chances of rethrombosis after reperfusion, and there is restenosis very commonly. We see that within a short period of 48 hours or within a short period of 6 months, and we have seen death also. So for that reason, to be careful, we or if alteplase or other recombinant TPA are not sufficient, then we introduce heparin in acute stages. Otherwise, most often fibrinolytics are more than sufficient, and these reperfusion due to use of thrombolytic agents are more likely with short-acting drugs, but less likely with long-acting streptokinase and urokinase. But the problem of allergy, bleeding, hypotension. These are the three main problems, but the restenosis and rethrombosis are very less with streptokinase and urokinase. So you have to judge and at least keep the patient for 3 days. So they may ask you why the patient is kept for 3 days. So you can answer in these formations, where we usually skip off these middle things. We see only the beginning and the end of the action of the drug. We do not see the middle one, which is very, very important, so that the judging will be very nice. Thus, heparin administration is not necessary if we use streptokinase, urokinase, but it is necessary when we use the newer ones, alteplase, tenecteplase, as well as retiplase. Anistreptase is no more used because it is also known as bolus. These are known as bolus for fibrinolytics, and they may cause rethrombosis. And all these are fibrin selective. These are fibrin selective. These are very important points. These are the ones which are given in MCQ questions. So you please remember all these things. Now coming to their indications. So in indications, we see venous thromboembolism and acute coronary syndromes are the main ones where we see this. So here in thromboembolic disorders, in case of prophylaxis of pulmonary embolism and DVT, especially in bedridden and high risk patients, we use these anticoagulants are the drugs of choice. So now there is little alterations. We use more of an LMWH, fondaparinux for initiation, followed by dabigatran for maintenance, because we need not monitor. That's the reason. Okay, otherwise you have to monitor INR. Prophylaxis for venous thromboembolism after orthopedic surgery. Nowadays, we give it as prophylactic LMWH. We do not give 3 or 4 doses. With one dose only, it will be more than sufficient, because we are using blocks. So your viva might be because of these things. So you have to know why these are used only for prophylaxis nowadays. Why? Because they are using blocks. Okay, they are not using spinal anesthesia or general anesthesia in all knee replacement, hip replacement, or any lower limb surgeries in orthopedics. They are using blocks than spinal anesthesia. When they are using blocks, they are asking the patient to move within about 24 hours. So there is no need at all. But to be on the safer side, we give a single dose of low molecular weight heparin or rivaroxaban, or even sometimes oral dabigatran or an injectable fondaparinux. And prophylaxis of stroke in such cases, and in non-valvular atrial fibrillation, we will try to give rivaroxaban, dabigatran, or warfarin, where other drugs are not necessary also. In acute coronary syndrome, where the thing has already taken place, in such cases, if there is no renal dysfunction, then we use these drugs. And in case of HIT, bivalirudin, and later on we use aspirin, clopidogrel previously, but now we are using prasugrel, but we have to see for bleeding. For maintaining patency after PCI, we still used unfractionized heparin, followed by warfarin for maintenance. Why? This is one of the favorite questions what we ask. See, whenever we want to start oral, especially warfarin, we initiate warfarin, but continue heparin, either low molecular weight or unfractionized, for about 3 to 4 days. Then withdraw this injectable ones and further continue warfarin. Why is it so? What is the rationale behind it? You have to know this without any doubt. Without any doubt, wherever you are working, if you are working, you are using it. Otherwise, you are refilling the prescription. So you have to know it. Both the ways, you have to know why unfractionized or low molecular weight heparin is used in presence of initiation of warfarin for about 3 to 4 days. Then we stop this heparin and continue with warfarin. So what is the reason behind it and why we should use it? Now, commonly used, this is one more revision for you people. Aspirin, dipyridamole are irreversible thromboxane synthase inhibitors. The first question, what I told you. Then ticlopidine, clopidogrel, prasugrel are these thienopyridine derivatives. They are all pro-drugs. What is a pro-drug? The drug which is not active outside the body but becomes active once it enters the stomach. And all these are irreversible P2Y12 receptor blockers. Prasugrel is the fastest acting one. That's the reason why we have started using nowadays. Ticagrelor is a reversible P2Y2 receptor blocker, which is, and all these are used for prophylaxis of arterial thrombosis. The one which are used IV are apixaban, kenaglol, and for percutaneous angioplasty, acute coronary syndrome, and to reduce the platelet loss during dialysis. This also you should be in your mind continuously. Now, this is about rodenticides, where we are using all these very commonly, and there is a prolonged PT and persists for a week, and most often this is accidental or homicidal poisoning. In such cases, you have to use vitamin K for a very long time also. Now, coming to some of the important things, what I want to tell you is the ones which are used for bleeding disorders and bleeding are coagulants and antifibrinolytic agents. Then used for thrombosis are heparin and oral anticoagulants, and for arterial antiplatelets, for lysis, fibrinolytics, or thrombolytic drugs. So please note the names: thrombolytic, fibrinolytic, antiplatelet, anticoagulants, oral anticoagulants, injectable anticoagulants, and antifibrinolytics and coagulants. Okay, now this is the most important one what we are facing nowadays. Heparin resistance can occur because of pharmacokinetic, that is absorption, distribution, metabolism, excretion reasons, or pharmacodynamic because of its action, antithrombin 3, factor 10, and factor 2. Because of these things, you can have resistance. Then there can be higher concentration of heparin binding proteins in plasma, competitively inhibiting the binding of heparin to antithrombin. The clearance may be accelerated and the resistance is detected. How do you detect? These are the reasons for resistance. How do you detect it? When the dose of the heparin needed to maintain the therapeutic APTT is increased. Only when it is increased beyond certain units, you you conclude it is resistant and switch on to other injectable anticoagulants. The same way we have aspirin resistance, and so thrombosis occurs in spite of aspirin. Patient says that he is taking aspirin continuously, but he comes back with thrombosis. So in such cases, you see these, and you have to change to either clopidogrel or ticagrelor or even prasugrel. And incidence is about 30%. Most often we do not see. Most commonly, 90% of the times we see melena commonly, or in patients who have got, they come with anemia more than melena. They come with anemia, then melena, then bleeding. So these are the ways they come, and so you have to suspect these first than going directly to all these abdominal surgeries or laparotomies. Especially small intestinal bleeding, we do not find. Recently, I had a patient who had small intestinal bleeding, where we found out only by clinical methods, not by any other methods. Patient came, because of hypotension, we put them on IV drips of all possible fluids. This was at home, it was not even in the hospital. It was at home. We started with drips and other things. Even after 6 hours, that hypotension did not come back to even to just normal blood pressure. Then we suspected, clinically, we suspected that something might be wrong somewhere, some small bleeding might have taken place. So we sent them to an hospital. So there they did laparotomy and found a bleeding in the small intestine, where it cannot be detected even by MRI or CT scan nowadays also. Even till today, we cannot detect small intestinal bleeding. I hope I am correct. Is it so, Dr. Kishan? Okay, now coming to the last one or two slides, takeaways, low molecular weight heparin. This is the standard one what we are using, but expensive, but no repeated monitoring. Low dose aspirin 75 to 150, most common antiplatelet drug. DAPA 325, 300 in acute coronary syndrome, post-MI coronary angioplasty. Now ticagrelor, but you have to watch for bleeding. In acid peptic disease, clopidogrel instead of aspirin. Ticlopyrin never used because of neutropenia. Anticoagulant drug interaction common, warfarin and NSAIDs. Oral thrombin inhibitors, dabigatran, but we do have an antidote for this dabigatran, or oral factor Xa inhibitors, rivaroxaban or apixaban. So now self-assessment, the last slide. Mark the wrong statement. Prophylaxis of DVT. Treatment of, I have mismatched it. You have to match it correctly. Prophylaxis of DVT. Mark the wrong statement. Prophylaxis of DVT, warfarin. Yes. But nowadays we can use low molecular weight heparin or oral thrombin inhibitors. Treatment of pulmonary embolism, definitely heparin. Prophylaxis of pulmonary embolism, urokinase, never. Why? Urokinase should be given IV first of all. It's a fibrinolytic. Prophylaxis of pulmonary embolism, you have to give either this low molecular weight or platelet, antiplatelets, we have to, or even peripheral vasodilators. Acute MI, obviously, streptokinase, we need not use heparin in such cases. The second question is preferred agent to prevent venous thrombosis in patient with HIT. Heparin-induced thrombocytopenia is low molecular weight heparin, lepidolin, warfarin, ticlopidin. Low molecular weight heparin we normally use for deep vein thrombosis. Okay, warfarin, oral anticoagulant, normally we use for prophylaxis. Ticlopidin never used because of neutropenia. So the leftover is all heparinoids, that is lepidolin, bivalirudin, etc. So lepidolin is the drug of choice where we use it to prevent venous thrombosis. Which of the following do not cause bleeding in overdose? Heparin, warfarin, aprotinin, urokinase. Heparin, the unfractionized heparin or low molecular weight heparin. Warfarin, oral anticoagulant. Aprotinin, which is the anti-fibrinolytic agent. Urokinase, a fibrinolytic. So, which is the one which causes which cause bleeding in overdose? It is aprotinin because it is an anti-fibrinolytic agent. Now, make the wrong match about antithrombotic agent and its antidote. And its antidote. Okay, dabigatran, idarucizumab, which we have seen, a monoclonal antibody. Heparin, obviously, actually stop the drug. Protamine, as I told you, if you inject little more, it itself acts as an antiplatelet and anticoagulant. Warfarin, definitely vitamin K. The other alternative, fresh FFP, fresh frozen plasma. Urokinase, avidin, no, not at all. Again, you have to use one of these. So avidin is the wrong one. Next, Mark the wrong statement about the drug use and route. See, you have to match all the three. Altiplase, acute MI, IV infusion. Is it correct? Yes. Enoxaparin, treatment of pulmonary embolism, subcutaneous. Obviously, 100% correct. Warfarin, prophylaxis of DVT, oral. Absolutely. But we are not using warfarin because of the said reasons. Heparin, treatment of pulmonary embolism, IM. Heparin can never be given IM. It has to be given only subcutaneous or IV. So this is the wrong statement what we have seen. Which is the bolus thrombolytic, altiplase, streptokinase, tenecteplase, urokinase. All are IV infusions except tenecteplase. In case of acute MI, fibrinolytic drug should preferably be administered within how many hours? Within how many hours? Time to needle time. How many hours? 6 hours. 4 to 6 hours. Which of the following agents can be used if there is overdose of fibrinolytic? Protamine for heparin, vitamin K for warfarin, ESCA for fibrinolytic agents. Fibrinolytic agents. All of the following are fibrin selective except retiplase, anistaplase, altiplase, tenecteplase. It is retiplase. Which of the fibrinolytic, sorry, tenecteplase. Which of the following fibrinolytic has more risk of bleeding? Urokinase, duteplase, altiplase, tenecteplase. It is tenecteplase. Okay, it is tenecteplase. So, just a word about coagulants, where you have to use local vasoconstrictors sometimes, or sometimes in case of postpartum hemorrhage, or sometimes in menorrhagia, or sometimes in systemic bleeding. In such cases, what are the drugs? Just a glimpse, and whatever I have written in red are the ones which are used very, very commonly. So locally, we normally use adrenaline or botropase, to adrenaline or botropase. Systemically, we use either plasma in when they are in hospitalized. Vitamin K can be injected or given orally for weeks together in case of poisonings. Fibrinolytic inhibitors, normally we use tranexamic acid or aprotenin. Nowadays, even ethamsilate also. Carboprost in case of PPH, and the other ones are normally used in ICUs or in wards. Sometimes we use sclerosing agents. I don't know how best we are using today. Normally, we tell them to use Kegel exercises rather than sclerosing agents. In case we want to use, these are the drugs which we are using. That is either phenol or ethanolamine or sodium morate, which are the ones which are very commonly used. Thank you very much.